I'm Dr Emily Farrell. I'm a pain physician working in a mix of public and private practice in Brisbane, and I am very privileged to be here today with Professor Nadine Attal, who has joined us all the way from France. We've just had a fantastic talk about the use of repetitive TMS, trans-cranial magnetic stimulation, in neuropathic pain, but also around some of the nociplastic pain syndromes like fibromyalgia. And I really wanted to ask you, what excites you about the use of RTMS as opposed to any of the other things that we use for neuropathic pain and then fibromyalgia?
Yeah, thank you very much for the question. I think, yes, it's really an expanding treatment for the treatment of chronic pain, in particular neuropathic pain, but also, as you mentioned, fibromyalgia. And the reason why it's expanding in analgesia is manifold. First of all, it is really safe. It's not an invasive technique. It has actually very few side effects except a few headache, but if you compare to the placebo in trials, no more than the placebo. So it's really well tolerated. There are very few risks. The risk is limited to epilepsy if you are an epileptic patient, and also you don't have to have cochlear implants, so because it's magnetic stimulation. But so there are very few contraindications and very few side effects. And we now see that, unfortunately, pharmacotherapy of chronic pain has limitations. The newer drug treatments, we're expecting newer drug treatments, but thus far we are using the older ones, and even those which are really widespread use, such as pregabalin, gabapentin. There are some concerns with some of them, some abuse concerns, and you also know about the opioid crisis. So we do need alternative therapy for chronic pain. And regarding fibromyalgia in particular, this is a condition in which pharmacotherapy is really limited. We do propose other modalities such as physical therapy, pain education, cognitive behavior therapy. And so RTMS has also a place in combination with all these techniques. And it really has also shown some efficacy in clinical trials recently.
Yeah. And currently it's just gone into a number of international guidelines with regards to the management of chronic neuropathic pain, and it's considered a third-line agent. Now, with that, I would think a lot of that has to do with some of the practicalities around how you have people, access it, because it's not something you can just prescribe and be delivered by the primary care physician and monitored. It requires people to come to a centre to use it. Often that means that perhaps the people who would best benefit from it don't actually get to use it. Do you think that if all things were equal and there was no problems with money or access, where do you think it should be in the guidelines?
You're quite right. It's a third-line treatment now in international evidence-based recommendations were recently published. You're right. It's the access is difficult. It's not widespread use. There are many countries in which it's difficult to use. It's really costly. You have to have a center. It's an in-hospital delivery. You cannot have it at home. So this is a major concern. However, for instance, in major depression in the United States or in other countries, they use it now very routinely. So we're hoping that with guidelines and newer studies, it will be easier to use and then maybe reimbursed for the treatment of some chronic pain conditions. I think that, of course, if it was even more available and if it costed nothing, then probably I myself, if I was a patient, I would probably prefer to use this treatment than a drug with a risk of somnolence, dizziness, weight gain, whatever, you see? So and my patients generally, they prefer this type of therapies than having risk of having abuse problems or, as I said, other side effects such as dizziness, drowsiness, and so on. So yes, I would probably put it earlier in the guidelines.
Yeah, well, it's interesting. In Australia, we are now also using the RTMS in depression with increasing availability and frequency. And I'm pretty sure, if I remember correctly, there's one of the Western Australian centres, the pain service and the psychiatry service share the same building, and there is a TMS machine there that does enable some use with that. But it does go to show that perhaps if we were more collaborative with our colleagues from other areas of medicine, we could share the resource and the costs involved within that.
Yeah, but you're pointing to a very true situation. In France, there are many physicians who collaborate with psychiatrists. For instance, in one of the biggest hospitals in Paris, Pitié-Salpêtrière Hospital, in which psychiatrists use it currently, they accept to use it for chronic pain as well. So you see that, yes, in some teams which do not possess their own machine, it is possible to collaborate with psychiatrists. But I do hope that, owing to newer studies, then of course the pain physicians and even maybe in any specialist and even primary care physicians would be able to use it in clinics or in hospitals.
Yeah.
Or something.
Yeah. Fantastic. Thank you so much for your time.
Thank you very much.